Hi, and welcome to today's episode of Guideline Review of the Week. This is a segment in which we discuss official guidelines and everything that pertains to a particular topic and has been officially accepted globally as a standard of care for that procedure or for that event or for that condition. So the topic for today is something that we often see being done in obstetrics is a procedure that one must definitely know, but there is still a lot of discrepancy when it comes to this topic, be it regarding the preoperative care and the drugs that are given, the selection of patients, the indications, and often we do see that these indications are stretched quite thin when we select patients, and also the post-operative care that should be given. We also shall be learning about all the contraindications to this procedure and the risks that this procedure brings along with it. This guideline was issued by the Royal College of Obstetricians and Gynecologists in June 2022. This was actually a guideline that they had already issued almost a decade ago and is something that they updated a couple of years ago to bring into it to accommodate a few changes that have occurred in obstetrics across the last decade. So, this guideline we shall be discussing every single part of this guideline in minute detail, and here we go. So, what actually is cervical cerclage, or what we also call as cervical encerclage? Encerclage, if I'm going to be simply speaking, is encircling. So, in this, we ensure that the cervix is encircled with a synthetic suture material so as to prevent the cervix from dilating. The work of cervix in obstetrics is to dilate and to let the baby deliver. So, we stop this process or we halt this process or we avoid the dilatation of the cervix in future by doing this procedure. So, very obviously, the question that arises here is why do we need to do this? A very easy answer to it to prevent preterm births. Now, we do not want a baby to be delivered before term because it carries its own risk of respiratory distress syndrome, fetal demise or neonatal demise, necrotizing enterocolitis, and all the other risks that pertain to prematurity. And hence, in patients in whom there is a risk or there has been a history of preterm birth or second trimester abortions before the baby even reached the period of viability, these are the candidates that we prefer to do cervical encerclage for. So, talking about the indications that we just mentioned, what are the actual indications for which this procedure is allowed? So, before that, I would want to tell you what are the different types of cerclages. So, in this, there are three locations where you can do cerclage, and then there are three indications where you can do cerclage. So, to summarize, before I start reading the guideline out, are if I'm to talk of the indications, then there are three of them. The first one is history indicated cerclage, in which a female has history of certain number of premature births or second trimester abortions in whom we do this procedure prophylactically to prevent a premature birth or a second trimester abortion. Apart from that, we have USG indicated or ultrasound indicated cerclage, and finally we have emergency cerclage. We shall be dwelling into each of this individually as and when we go ahead with the guideline. These were the indications. What are the locations? Just like we have three indications, we have three locations as well. The locations can be divided into a low vaginal or what we call as the McDonald's cerclage. Then we have a high vaginal in which we have the procedure that we call as something that we have to be proud about because it was an Indian gynecologist who gave it. Shirodkar's Cerclage. In fact, Shirodkar's Cerclage was so famous that a lot of women, even from Europe and US, a lot of celebrities would come to India to get this Cerclage done from Dr. Shirodkar, who was a gynecologist from Mumbai, a legendary gynecologist from Mumbai who has several other procedures to his name as well. Apart from this, there is the abdominal cerclage. So these are the three locations in which we can do. This is the one that is the easiest to be done and the one that most people do, whereas the most secure one is this. This one, the high vaginal, the Cervical Cerclage, is slightly difficult because it involves taking the bladder upward, dissecting the bladder, but is a much more secure cerclage than what a low vaginal cerclage is, but is definitely lesser secure than what an abdominal cerclage can provide. We shall be reading a lot more of this as we proceed into this guideline. So, the first thing that we shall be studying is going to be history indicated cerclage. So this is a guideline. I have taken snapshots, I've taken screenshots from the guideline in entirety, and that is how we shall be reading each and every line of it. After you're done with this topic today, after you're done watching this video, which will last for around half an hour to 45 minutes, I guess, you will be well versed with not just this guideline, but also with this topic from Ian Donald, that is a book of obstetrics, and Williams. So the first one that we shall be talking about would be a indication, and that is a history indicated cerclage. Now, what is technically the definition of history indicated cerclage? To summarize, that this cerclage is first of all done between 11 to 14 weeks of gestation. This is done in between 11 to 14 weeks of gestation, and this is done, I shall be coloring this part. It is done in women who have singleton pregnancies and who have had three or more previous preterm births. So it is for women who have had three or more preterm births or second trimester spontaneous abortions. Second trimester spontaneous abortions. It can be two of preterm and one second trimester, or it can be all three second trimester, or it can be all three preterm, or it can be one preterm and two second trimester abortions. It doesn't matter. The history has to be though three or more than three. This they do say, in fact, the guideline says that this should not be offered to women, should not be offered to women who have less than three preterm births. Now, this is the first discrepancy point over here. Often in our country, I often see patients in whom, even with history of one preterm birth or one, what do I say, one spontaneous abortion in the second trimester in the past, women are given without even the ultrasound criteria being fulfilled, merely on the basis of history. Women are being women are being told that they require a cerclage, and it is often done from them. But if I'm going to be talking strictly in terms of guidelines, then definitely it is not to be done if there is a history of less than three. Though I do understand why this discrepancy arises, the fact is that a female cannot afford to keep on losing a pregnancy, especially when they're in second trimester or having a baby that stays in an ICU when it is born with preterm labor. So it is something that is not acceptable neither financially nor as a social or emotional thing for the couple to have such a baby. And hence, I do believe that this discrepancy has this logic behind so as to prevent further trauma to the female, to avoid further monetary expenses that are incurred by the female when she gives birth to a preterm baby. This is done even after one history of preterm labor. But officially, the guideline says that it cannot be done if there is less than three history of less than three preterm births or spontaneous abortions. What's next? This is about history indicated cerclage. In this has to be done between 11 to 14 weeks, and we can call this as something like a prophylactic cerclage. Prophylactic is basically we are doing this to avoid a subsequent preterm birth or second trimester abortion. Obviously, it is done in the later first trimester so as to prevent a second trimester abortion in women who have a history of the same. Hence, the ideal time is between 11 to 14 weeks of gestation. The next one is ultrasound indicated. So in ultrasound indicated, this is done between 14 to 24 weeks of gestation. Now this is which is often used by a lot of practitioners to their advantage, or not to their advantage, or for the benefit of the patients, I'll say. It mentions that women who do not probably have a history of three or more than three uh, preterm births, but even if they have a history of one preterm birth or one spontaneous abortion, and it is accompanied by, if a female has history of more than one or one, I'll write it as preterm labor or second trimester abortion. If along with this or in addition to this, if this female has ultrasound characteristics of a cervix that is less than 25 mm or 2.5 centimeters, whatever you may say, this female is a candidate for ultrasound guided cerclage. Now, what is this period of 14 to 24 weeks? Now, this is a period in which the cervix first starts dilating if it has a short cervical length, what we also call as cervical insufficiency or inadequacy. Basically, the cervix starts giving way. वो बहुत ही ऐसे पतला is not the word. We can say it starts getting weak. It starts getting dilated before time, and this is the period when it actually starts dilating. So we have to be doing ultrasound in this period so as to we know if this female stands a chance for being a candidate for ultrasound guided cerclage. Over here, you can see the same thing that I just spoke, that for a female who has history of one or more than one second trimester abortion or a preterm birth, and if her cervix is less than 24 mm at gestations less than 24 weeks, so basically between 14 to 24 weeks, when this female will be a candidate for an ultrasound indicated cerclage. It also says that if a female does not have, if a female is not having a history of this preterm birth, if she does not have this part in her own history, and all she has is an ultrasound finding that is less than 25 mm of cervix, these patients should not be subjected merely on the basis of an ultrasound finding of a short cervix. These women should not be subjected to a cerclage. This is what this says, in the absence of, not only in the absence of more than 25 mm, but if either of these criteria, I would like to modify what I just said. If either of these criteria are absent, if the ultrasound is not showing a cervix that is less than 25 mm, but she has a history of a preterm birth, or if she has a history of preterm, or if she doesn't have a history of preterm birth, but this current pregnancy does not show an ultrasound of more than 25 mm, either of these criteria are absent, this female is not a candidate for ultrasound guided encirclage. Now, RCOG defines two categories for women who are at a high risk of second trimester abortion. Now, what are these high risk categories? One is a high risk category, and the second category is an intermediate risk category. So, these are the candidates, or these are the patients who should be undergoing ultrasound guided cervical length measurement between 14 to 24 weeks. So, women who are at history or who have a previous birth, even one birth, who have a previous birth or second trimester loss, so even one or more than one losses, or a female who has had PPROM at less than 34 weeks, or a female has history of a cerclage done in a previous pregnancy, or as a uterine variant. By uterine variant, we need to say over here if she has any Mullerian anomaly. If she has any Mullerian anomaly, by Mullerian anomaly, I wish to say over here anything like unicornuate uterus or a bicornuate uterus. If she has any of these, then, and if she has intrauterine adhesions or what we also call as Asherman syndrome, these patients are at a high risk of having preterm birth or second trimester abortions. So these are the patients who should not directly undergo a cerclage, but they should be undergoing an ultrasound guided cervical length measurement between 14 to 24 weeks at an interval of every 2 to 4 weeks. So roughly every month, these women between 14 to 24 weeks should have their cervical length measured. And if the cervical length goes below 25 mm or 2.5 centimeters, you do a cerclage for them. Also, one more risk factor that we have spoken over here, which is a high risk factor, is history of trachelectomy. Now, trachelectomy is not a procedure that is done too often. Trachelectomy, or I can add one more thing for females who have undergone a procedure called as Manchester Fothergill repair. Manchester Fothergill repair is something that is done for women who have cervical elongation. It's a type of pelvic organ prolapse जिसमें there is cervical elongation and the cervix comes out through the vagina. These are the patients in whom we do trachelectomy. In trachelectomy, or what we call for these women Manchester Fothergill repair, we ampute the cervix and we reduce the cervical length. Trachelectomy, on the other hand, is a procedure that is done for women who have early stages of cervical cancer, stage 1, if I'm to be more specific, and women who have a lesion which is less than 2 centimeters of cervical cancer, and they desire to have pregnancy in future. They do not want their uteruses to be removed, and hence these are the women who undergo a trachelectomy. So these are also women who are at a very high risk of having a weak cervix or having a cervical length less than 25 mm, and they have to be measured, or their cervix has to be measured for every 2 to 4 weeks between 16 to 24 weeks. Apart from these, there are women who are at an intermediate risk. Now, which are these women? These are the women who have had a previous LSCS in second stage. A second stage, I mean at full dilatation. The second stage of labor is when a female has complete dilatation of her cervix. When she has had complete dilatation after 10 centimeters of dilatation, they often result in sections in which the cervix can be transected while doing a cesarean section, and this can lead to a weak cervix in the next pregnancy. Also, women who have a history of not trachelectomy but removing a part of the cervix as a part of cervical intraepithelial neoplasia. Now, we have learned that there are pre-invasive lesions. There are pre-invasive lesions of the cervix which we call as CIN, cervical intraepithelial neoplasia. We have 1, 2, and 3. So 2 and 3 are high risk CINs in which we often do procedures like loop excision of, or I'll just write it in short, we do loop excision of transition zone. So we do these procedures, LEAP, or we do LETS, or we do conization, in which we remove a cone-like shaped part of the cervix where the cervical intraepithelial neoplasia is present. In this, we are not amputing the entire cervix as we would in Manchester Fothergill repair, but nor are we doing a complete trachelectomy, but we are removing a part of the cervix. But that part of the cervix is sacrificing a few smooth muscles and also collagen from a cervix, which can eventually lead to cervical insufficiency. So these are women who are at an intermediate risk, and these women merit at least one evaluation with ultrasound. These women merit at least one evaluation with an ultrasound, should undergo a single transvaginal scan no later than 18 to 22 weeks. So between this 14 to 24 weeks ka period, you have to undergo one ultrasound at least in these intermediate risk women to see if the cervix has shortened below 25 mm. Now here we are done with two types of encephalitis based on indication. The first one was history indicated and the second one was ultrasound indicated. The third one that we shall be talking now is an emergency cerclage. Emergency cerclage, or what we also call as a worms, WURM, worm stitch. This is something that you may not find in a lot of books. It's a worm's stitch that we take. Basically, in this type of cerclage, just speaking about it, if this is your cervix that you're seeing, a worm stitch is taken. You take two sutures, one would be like this and the other one would be like this. So this is a worm stitch that you take for cervical encerclage when you do it on an emergency basis. Anyway, so when should a rescue cerclage be done? They say that rescue cerclage has to be done when there has to be a balance between baby's mortality and the risk of the procedure to the woman. You cannot be doing a cerclage. By the way, when do we do this? We do this. हमने देखा था कि history indicated is done from 11 to 14 weeks. Then we do ultrasound guided between 14 to 24 weeks. And finally, we do this, that is emergency cerclage between 24 to, or I can even say less than 24 to 28 weeks. We do not do it above 28 weeks. This can definitely be done if it is happening below 24 weeks, but preferably the period of duration in which this is done is between 24 to 28 weeks. Now, you would ask me why 28 and why not something like 34? And you may have even seen that patients have had a cerclage done at 30 to 32 weeks of gestation. Now, the answer to this is that often women who come to you at 30, 32 weeks of gestation with premature dilatation of the cervix, these women are often in proper labor. If you're going to be doing a cerclage, it can lead to cervical tears, cervical lacerations, or you may end up placing your needle, that cerclage का जो needle होता है, inside the membranes which are coming out, the amniotic membrane that is coming out. This will lead to further accentuation of the preterm labor, and hence it has to be done till 28 weeks. Why also 28 weeks from baby's point of view? Now we have adequate NICUs, that is neonatal ICUs in our setups that can make a 28-week baby survive. So till 28 weeks we can do it. It is said that it gives me around 4 to 5 extra weeks after I'm done with an emergency cerclage. So if I'm going to do a cerclage at, let's say, 27 weeks of gestation, it gives me around 4 to 5 weeks, which means that I'll be able to pull the pregnancy till at least 32 to 34 weeks of gestation, which is good enough for a baby to be able to survive in an outer environment. So the decision has to be individualized, they say, but it has to be preferably done till 28 weeks of gestation. And as this says, that it helps in delaying, but 34 days. 34 days is approximately 5 weeks. We get around 5 weeks in addition to the procedure for the pregnancy to be prolonged. So we have learned three indications. The first one was history indicated, the second was ultrasound indicated, and the third one was emergency indicated. The history was done between 11 to 14. The ultrasound guided was done between 14 to 24, and this is done from 24 to 28. Also, obviously, as we have mentioned that why is it not done after 28 weeks? Because if a female is coming to me in labor at around 32 weeks, they are often in proper labor, proper preterm labor, and these are candidates who should not be given circulars because it might lead to cervical tears. And hence, as they mention over here, that more than 4 centimeters of dilatation of membrane or membrane prolapse outside the external os is associated with a high chance of cerclage failure. So not only will the cerclage fail to do what it was intended to, it will also lead to those tears that can happen. Now, based on location, we have already spoken about two locations, that is the low vaginal and the high vaginal. So if this is your cervix, let us assume this is your cervix and this is your uterus. The first level of cerclage is done, which is done in most of the institutions as is an easy procedure to be done, is done at this level. This is the McDonald's procedure, and very easily done. The other procedure that we shall be doing is done at the location which is a slightly higher vaginal one, and we call this the Shirodkar's procedure. In this, you need to dissect the bladder. यहाँ पे if you know, you will be having your uterocervical ligaments. In this area, you will be having your uterocervical ligaments. So in this, you have to dissect the bladder. I'm not drawing. Okay, fine. I'll draw it on this end as well. So you have to dissect your bladder, which might be coming over here. If this is your bladder, it might be coming. You will have to dissect the bladder upwards so that it doesn't come in between your suture line. So the bladder is dissected upwards. And the third location in which a cerclage is done is an abdominal cerclage, which is done at the level of isthmus. So it is done at this end, and we call it the abdominal cerclage. Obviously, an abdominal cerclage has to be done intra-abdominally. For that, you can either opt for, as we shall be learning ahead, we can either opt for an exploratory laparotomy, wherein we open the abdomen by giving an incision on the abdomen, or we can do it by laparoscopic route. Obviously, laparoscopic route is associated with lesser complications and is the one that is preferable if you have the resources to do that and if you have the expertise to do that. So, a transabdominal suture, when is it done? The first question, it is done in women who have had a previously unsuccessful transvaginal cerclage, or in women who have, this is also done in women who have no cervix. So what are the indications for doing a transabdominal cerclage? There are two of them. The first one is a failed transvaginal cerclage, or in women who have history of trachelectomy. They hardly have any substance left in their cervix. So if there is no substance, how will you even do a transvaginal procedure? So in these women, you do a direct transabdominal procedure. How do you do it? It is again mentioned over here, a laparoscopic route or an open abdominal route can be preferred, but laparoscopic route is associated with fewer complications and hence is the preferred one if you have the resources to do that. Now, when I talk about an abdominal cerclage, the next question that comes is, obviously we have often seen patients coming to our emergency ward with vaginal cerclage been done. We cut the tape and we deliver the babies. What if the same thing were to happen in a female who has an abdominal cerclage? So, what do I do in women who experience either a miscarriage or a fetal death? So, in these women who have had a miscarriage or a fetal death, they say that you can do it with the abdominal cerclage in situ. You do not need to do anything, so a complete evacuation of the products can be done through the stitch by suction curettage or suction and evacuation or dilatation and evacuation till 18 weeks of gestation. But if you feel or rather if the gestation is quite progressed, if it is let's say at around 28-30 weeks of gestation when there is an intrauterine fetal demise, or if you are unable to take the products out, then what you can do is you can do a posterior colpotomy. So basically I'll be opening up the pouch of Douglas from the posterior vaginal wall. So if this is my cervix, this was my anterior end, and this was my posterior end, I'll be pulling the cervix upwards and I'll be seeing the posterior vaginal wall. And in the posterior fornix, I'll be opening it, which is something that we call as posterior colpotomy. That is something that we do in vaginal hysterectomy as well, what we call as the opening of P pouch, posterior pouch. So we'll be opening the posterior fornix and I'll be reaching out to the cerclage and then I'll be cutting it so that I'll be able to deliver the fetus. If even all of this fails, then finally there is no option but to do a hysterotomy or a cesarean section. Basically, you just open the abdomen and you open the uterus and you remove the baby out. So this is the last thing that you can do. So for a transabdominal encerclage, if by the way it's a full-term delivery, you have to deliver this baby by cesarean section. There is no question of delivering it through vaginal route. But if there is an IUFD that has happened before term or there is a delayed miscarriage, if there is a product that has to be removed from inside, you can either do it with the cerclage in situ or you can do posterior colpotomy and cut it open, or the third option would be opening the abdomen, opening the uterus, doing a hysterotomy or a cesarean section, and then you deliver the baby. So, the most important questions, who are the patients in whom we should not be doing the cerclage? Now, there is this saying often that they say that a doctor spends his first 5 to 10 years learning how to do things and on whom they have to be done. Whereas after those 10 years, the next 5 years are spent on knowing on whom not to operate or what not to be done. So you learn on who not to operate or what not should be done after you are done learning the part on how is it done. So to know on whom we should not be doing this encerclage is a very vital thing. Obviously, in teaching institutes, we keep a very low threshold for encerclage like procedures, which are not that common as a cesarean section, so that students can learn. But you should always be learning the ideal things, and the ideal thing they say is obviously if a female has come to me in active labor, if a female has come to me in active labor, if I'm going to do a cerclage, it is going to end up leading to cervical tear. The cervix is anyway getting dilated, and if you end up trying to do, if you try to do some suturing around that area, the cervical dilatation will still progress. It will end up tearing the cervix wherever you have taken those stitches. So never do it in patients who are in active labor. In patients in whom there is a clear evidence of chorioamnionitis. So imagine a patient has leaking per vaginum and you end up doing an encerclage. So if you're doing, which in fact is also a contraindication, here you can see a vaginal bleeding or leaking per vaginum. If it is happening in a preterm patient, you should not be doing this. Why? Because then you end up exposing the fetus to the outer environment because the membranes have ruptured. This gives rise to an increased risk of having infections that will be caught up inside. The microbial organisms will be caught in the uterus, they'll be stuck in the uterus and they'll multiply, and this will lead to chorioamnionitis. So whenever there are signs of chorioamnionitis, you have to deliver the fetus immediately, so that once the fetus is delivered outside, the membranes are delivered outside, the placenta is out, the risk of chorioamnionitis for the mother decreases, and also the baby will not be affected by that chorioamnionitis. So a very strong contraindication is if there is a chance or if there is any sign of chorioamnionitis. How do I know if there is chorioamnionitis? Very easy. The female will give you history of fever. The vagina will feel warm. If you do her blood test, then you will see that there is leukocytosis, that is increased WBC counts. You will see that the female will be having raised CRP, C-reactive protein. If you send a high vaginal swab for these women, it will show the growth of organisms. So these are the patients in whom you shall not do encerclage. Apart from that, if there is any chance or doubt of fetal compromise, if there is any fetal distress, if the fetal heart rate is not felt, is not heard properly, or if the fetal heart rate isn't good, you definitely don't do it. The fetal is in compromise. By keeping it inside, you're only giving rise to the risk of an intrauterine fetal demise, which you'll have to deliver anyway. Apart from that, if there is a lethal fetal anomaly, obviously, if there is a lethal fetal anomaly in which a baby is something like anencephaly, if a baby is having something like anencephaly and it is inside, or if something like skeletal dysplasia, if that is there, then you should not be doing an encerclage because you are giving rise or you are leading to the birth of a defective baby which will die anyway. So do not do a surgical procedure which has its own risk for the sake of the mother and the baby. Rather, you terminate the pregnancy, you do a medical termination of pregnancy, and you do not proceed with it. And hence, one of the prerequisites for doing an encerclage is to have a scan on your file which shows that the baby that is inside is normal and does not have any lethal fetal anomaly. Apart from that, obviously for fetal death, there is no point of prolonging the pregnancy. It will in fact lead to disseminated intravascular coagulation, DIC hoga, deliver the baby. What should you be telling the patient when she asks you कि sir ये मुझे encerclage करना करा रहे हो आप उसके risks क्या है? There are two major risks. The one is cervical trauma and the other one is bladder damage. But this bladder damage is more so seen when you're doing a Shirodka cerclage. So you should be telling that there is a small risk of this happening. Apart from that, I can end up accidentally pricking the membranes that are inside and I can lead to a rupture of membranes which will necessitate delivering the baby. So there is always going to be a small risk and this risk is going to be very high in whom I'm doing an emergency cerclage. An emergency cerclage is done for women who have a partially dilated cervix. Now if this was your cervix, this is dilated and you have membranes. I'm going to show with green. If you have membranes that are coming out through your external through your cervix. These are women in whom there is a high risk of membranes rupturing while doing the procedure. And emergency cycler does what? It takes a stitch in this area so that I can send these membranes upwards or I can keep these membranes ऊपर ही जितना है उधर and not letting them progress beyond this external loss. But it always carries a risk of rupturing the membranes. Hence, you have to do it very carefully. Hence, what we often do is we keep the female in a head low position. When the head of the female is kept lower, the baby goes towards the mother's head in the uterus and the pressure of that fetus on the membranes reduces. So those membranes often reduce themselves. Apart from that, we take a sponge holder, we put cotton on it and we push the membranes gently inside while we are doing the procedure, or we can even use a Foley's, an inflated bulb of Foley's for doing the same thing which we are doing with a sponge holder to avoid pricking the membranes. But there is always going to be that risk. There is obviously, as we have already spoken, a risk of associated cervical laceration or trauma and spontaneous labor. A higher vaginal cerclage, which requires bladder mobilization, can have not only the anesthetic complications because of prolonged anesthesia period, but also the risk of bladder injuries, especially in women who have history of previous cesarean section. These women will have the bladder that might be adhered to the lower segment of the uterus or the cervix, and hence these are women who are at a very high risk of getting their bladders injured. What about women who are undergoing a non-emergency cerclage? Similar risks, just that the risk of preterm premature rupture of membranes are increased, or the risk of cervical laceration also increases in them. So now that we have decided that a female does not have any contraindications, I've explained to the female that these are the risks. She is fine with it. We are going to proceed with the surgery. We have one of the three indications that we have fulfilled. We have selected that we shall be doing a transvaginal procedure for this female. So what are the investigations that should be done? Obviously, as I just said, that there are two major scans that have to be done. One is a first trimester ultrasound scan and screening for aneuploidy. Basically, aneuploidy hai ya nahi. If the fetus has anything like Down syndrome, Turner syndrome, you have to be checking for that. Or if the female has come slightly later to you, then you also have to be doing a malformation scan to check a second trimester TIFA, or I'll call it. So there are two things that I have to check. The first is a first trimester scan to not only know whether it's a viable fetus, but also to check if it's a singleton fetus. In first trimester, by the way, this if there are any aneuploidies, so I can be doing a test for aneuploidies. Apart from that, in the second trimester, I shall be doing a TIFA, that is targeted imaging for fetal anomalies, or what you also call as the anomaly scan. These are very two important prerequisites for me to know that I'm keeping a good baby inside and not giving the female a bad baby, which I'm saving till term. So these are the two investigations that are very necessary to be done. Apart from that, if a female has any history of PPROM or PROM, not PROM technically because that happens at term, PPROM, that is preterm premature rupture of membranes. In these women, we have to check whether the female, or if she's giving me a history of fever along with dilatation of the cervix, I have to be checking her maternal WBC count for leukocytosis and C-reactive protein to know. Apart from this, there are few more things that you can check. One is something that we call as fetal fibronectin. Fetal fibronectin is checked in the vaginal fluids. This gives me, if this is raised, this gives me an indication that the female is probably going to deliver before term or she's already in preterm labor, whereas the absence of this has a great negative predictive value. This is an experimental thing though, and hence should not be recommended for all women. Apart from that, should we be sending a high vaginal swab for all women? Now they say that routinely I should not be sending a high vaginal swab, or what we also call a genital tract screening. But if you feel that there is a clinical need to do it, by clinical need I intend to say if there is any chance of female having fever or she's having excessive white discharge, then in these patients you can consider, and hence they say that it should be decided on an individual basis after discussion with the microbiology team. Should we be giving preoperative antibiotics? We routinely give it in India, though they do say, in fact, the antibiotic policies are very stringent overseas, and especially in RCOG, they are very stringent. So they do mention that though it is at the discretion of the treating gynecologist or the obstetrician, in our setup, we definitely do give preoperative antibiotics, and this not only helps in having a good perioperative period, but it also reduces the chances of the female getting chorioamnitis because of the procedure that we shall be doing. And especially in people who are working in civil hospitals, where women from the lower socioeconomic strata come, they have a lot of infections. They often end up having a lot of vaginal infections, and these are the women who should be given perioperative antibiotics. And hence, I do recommend that we should be giving perioperative antibiotics. At least one dose should be given prior to the procedure, if not giving them post-operatively. Should we be given, a very important question, should we be given perioperative tocolysis? A lot of people give these women isoxsuprine, or what we also call as duodenone. There are also people who give these women tocolysis in the form of nifedipine, that is capsule depin. They say that there is no evidence that states that giving this routinely, there is no evidence that giving tocolysis routinely is going to affect the outcome of the cerclage, but this can be considered on an individual basis. If you think that the female is having contractions, if the female is having a uterus that is not relaxed, is having activity, then you can consider giving it to them. One more point that has to be noted over here is there are multiple observations that whenever you do any procedure that ends up touching the uterus, there can be an initiation of preterm labor. Also, the perioperative stress that is induced in the body because of all the anesthetic drugs, the stress of the female about the procedure, and the procedure by itself can at times occasionally lead to uterine activity. This uterine activity can be suppressed by giving tocolysis, but it is not routinely recommended. In our setup, we do not give tocolysis. This, though, can be given if you're considering an emergency cerclage, which is in later second trimester or even in early third trimester. So, not recommended, but can be given if you feel that the uterus has activity or there are slight contractions. But remember, do not give if the female is in active labor. The contractions, if they're with a closed cervix, you can give it. But if the cervix is 4 to 5 centimeters dilated, you do not suppress that activity. The baby is anyway going to deliver. You'll end up rupturing the cervix. You'll end up injuring the cervix. So don't do it in that case. What are the techniques that should be used, and what is the suture material that should be using? The choice of suture material should be at the discretion of the surgeon, but only ensure that a non-absorbable suture is used. Obviously, because if I'm going to be using an absorbable suture, this absorbable suture will end up leading to fibrosis and permanent occlusion of the cervix. I do not want that. I want that suture to be there till I want to deliver the baby, and I'll remove it once I'm done delivering the baby. So I do not want a suture that will end up closing the cervix permanently. So use a suture that is synthetic and is non-absorbable. So what are the options that I have? There are two options. I can either use I can either use a monofilament. This is something that we use in our setup, and that is ethylon or nylon suture. Ethylone is the brand name, nylon is the material from which it is made. You can either use monofilament or you can use braided or what we also call as multifilament. In multifilament, you have the option of using polyester. Another option that you have of using is Mercilin tape. Again, something that is very often used. You can use either of these. In my opinion, or in my practice, we have used monofilament sutures, nylon sutures to great effect. We use nylon number one. Echelon number one is what we use. So yes, definitely you can use this. You can even use the double-stranded loop echelon can be used, but something that I wouldn't recommend because pure echelon number one suffices in getting that procedure done. If you're doing a trans-abdominal procedure though, prefer to use a Mercilin tape because there's a larger mass of tissue that you will be taking it inside your sutures. Apart from that, the choice of suture the choice of procedure that has to be done is at the discretion of the surgeon, is at the discretion of the obstetrician. It is upon you to choose what you're comfortable with. If you're going to be doing a vaginal procedure, Shirodkar is better than McDonald, but McDonald is an easier procedure which can be done at all levels by all gynecologists who are not trained with bladder dissection. Whereas if a transvaginal procedure has failed earlier, then you go ahead with a transabdominal procedure, but it is completely at the discretion of the obstetrician and his or her expertise. Also, they mentioned that there are people. There used to be studies wherein they said that apart from doing an encerclage, they would insert a cervical occlusion suture. So there were two sutures that were placed. There is no point of doing this. Once you are done putting one suture for that cerclage, there is no need for placing another suture or putting a cervical occlusion suture for that. Should women be receiving progesterone supplementation? Should they be receiving it? Again, a very dubious point, something that has a lot of what do I call it? A lot of discrepancy in it. But if I'm going to be talking about strictly on what they follow in RCOG, they recommend that you should not be giving progesterone. But even in our setup, and I personally prefer to give progesterone, reason being that progesterone is known to keep the uterus quiescent. By quiescent, I mean it is known to keep the uterus calm and quiet in simplistic terms around the time of procedure. So before or around the time I'm doing any procedure, I prefer to give these women one shot of an intramuscular progesterone. Apart from that, I do not give these women progesterone for a longer period of time. But RCOG says you do not need to give it at all, let alone for one shot. In my opinion and in our practice, I do give it, but it is not recommended by RCOG. Now I'm done with the procedure. I'm done following all the instructions. When do I remove this? So if I'm going to be removing this, the point that it has to be removed, if I'm going to plan a vaginal delivery for this female, then it has to be removed at around 36 to 37 weeks of gestation. So technically speaking, it has to be removed between 36 to 37 weeks of gestation on an OPD visit. This is if I'm planning a vaginal delivery. Whereas if I'm planning an elective cesarean section before she goes into labor, then I can remove it by 39 weeks if I'm planning an LSCS anyway. If I'm planning an elective LSCS anyway. When are the other reasons? When are the other times when I can remove it? The other times when I can remove this is when a female is going into PPROM, when she has PPROM. So over here, which I can see in the next guideline, in women who present to me in PPRM, that is preterm premature rupture of membranes, between 24 to 34 weeks of gestation, delay can be practiced till 48 hours. By 48 hours, the reason is so that I can do in utero transfer. Basically, it means until I transfer the patient to a higher center, which will have the availability of a good and efficient NICU, and also to ensure that this female receives adequate antenatal corticosteroid cover for the fetus ka lung development to happen. So in women between 24 to 34 weeks, I'll write it here. So women between 24 to 34 weeks of gestation, these are women for whom I can delay it maximum until 48 hours till they receive steroid cover, complete steroid cover, and till they are transferred to a higher center, referred to higher center with NICU. But if a female is coming to me at 24 to 34 weeks of gestation with PPROM and with signs of chorioamnionitis. She has WBC counts, she has, let us assume, WBC counts that are raised, or she has fever, or she has raised CRP. These are women in whom I would not practice this delay. These are women in whom I will remove the suture immediately. As this point over here, in the second point over here mentions that delayed suture removal until labor can be associated with an increased risk of maternal and fetal sepsis. So it is only required till you give the female steroid cover and the female is transferred to a higher center. What below this and after this? Below 24 weeks and after 34 weeks, this is a period when the fetus will anyway not survive. So remove it immediately. All you're doing is giving rise to complications if there is PPROM between this period. Remove it before 24 weeks because it's a non-viable fetus. You will only give rise to maternal sepsis. And after 34 weeks, there is no point of delaying the removal because the baby is now good enough to survive in the outer atmosphere. The fetal lungs are quite developed, and all you are doing is going to be giving rise to the risk of chorioamnitis, which will harm the baby as well as the fetus. So if a female is coming to you with PPRM before 24 weeks and after 34 weeks, remove the suture. If she's coming between them, if your center is not a higher center, then keep it in situ till she is referred to the higher center and till she receives the steroid cover. But if she comes between 24 to 34 weeks of gestation to you and she has signs of chorioamnitis, you remove them immediately. Chorioamnitis or signs of proper labor. So this is how we manage a patient with cervical encerclage. I hope this session helped you a lot in understanding what are the indications, what are the different types and the locations in which we can do a cervical encerclage, and what are the contraindications to the procedure and the pre and post operative management that you have to be giving for these patients. If you have any doubts, please reach out to our team. Thank you for your patient listening. I shall see you next week in yet another topic under this segment. Thank you.